All right, guys, just a little review for those of you who are in my class and are headed into the Adult Med-Surg HESI and then Adult Health 2. So perfusion is actually a rather large chapter in your book, and it starts on page 1109. And just understand this is just a brief, and I mean very brief, overview to get you guys started. As usual, make sure that you guys take a second to look at the learning outcomes, and then we'll get started. Okay guys, being honest, do not skip the anatomy and physiology of the heart. It's probably the first dozen pages or so of this particular chapter, but it is absolutely necessary. Now we're going to just go over a few of the terms, and the first term that we're going to talk about is pulmonary circulation versus systemic circulation. You guys probably remember this pretty well. You know, pulmonary circulation just is where the right side of the heart, the pulmonary arteries, the capillaries, and the vein are involved. We know that we get the deoxygenated blood on the right side of the heart. It goes through the right atrium down into the right ventricle. Boom, we open up the pulmonary valve, goes out into the lungs where we have an exchange of the carbon dioxide and oxygen. And then we know that it is filtered out into the rest of the body to meet the needs of the body tissues. We understand then the systemic circulation gets involved. This is the high pressured system. We know that it is responsible for moving the blood to the peripheral areas of the body. It involves the left side of the heart, and it then branches into the systemic arterial system, the capillaries, and it supplies the brain and the peripheral tissues. When we get into the coronary circulation, you guys understand that this is a network of vessels that supplies the heart muscles. And when you guys look at the picture on page 1115, you can see the different major coronary arteries that supply the heart muscles. You guys remember cardiac output, and I know that you guys remember cardiac output, and you understand when we're talking about cardiac output, we're talking about the stroke volume times the heart rate. And we'll talk a little bit more about this later in the PowerPoint. So we're talking about stroke volume. That's that amount of blood that is just resting in the ventricle at the end of diastole. And so it actually has a number. It's supposed to be around like 70 to 100 for an adult. And then we know that there's the heart rate. These two make up the cardiac output, and the cardiac output is just the amount of blood that's pumped out by the ventricles into the circulation in 1 minute. Now, maybe you guys have not heard the term cardiac index, but the only difference is cardiac index takes into account how big you guys are, so your body surface area. So I always give the example that we have Shaquille O'Neal. I think he's like 7'1", and he has a lot of body surface area to cover. His heart has a big job. And then if you think about someone who's really tiny, maybe who's only like 5 foot tall, then their heart does not have as much body surface area to cover. And so sometimes cardiac index is just a little bit better of an indicator of how well the heart is working, because it takes into account how large your patient is, or the body surface area. Now, when you're looking at ejection fraction, we were talking about the stroke volume, right? So ejection fraction looks at that, it measures that, it takes into account what percent of the stroke volume is being ejected. And so if you're looking in your book at page 1115, it says, for example, an end diastolic volume of 120 mLs divided by a systolic volume of 80 ml leads to an ejection fraction of 66%. And so it's just telling us how effective is that ventricle at ejecting its blood volume. And a normal ejection fraction, guys, is between 50 to 70%. And this is something that we look at when we have someone that we know has declining heart function, for instance in cardiomyopathy or heart failure. And then cardiac reserve is just what kind of reserve do you have available to you. And cardiac reserve is the heart's ability to actually respond to an increase and strenuous activity, but maintain cardiac output. And as you guys could understand, cardiac reserve actually diminishes as we age. And then the one that I actually skipped here, ischemia. Hopefully you guys understand ischemia, but ischemia just means that the heart muscle is being deprived of oxygen. And this is not a good thing. Tissues need a constant supply of blood flow because they need nutrient and oxygen. And the heart muscle is no different. So when we have cardiac ischemia, it means that there is an altered blood flow and the heart muscle is being deprived of oxygen. Okay, so we've already talked about cardiac output, right? We talked about cardiac output, and we talked really about the fact that maybe we're going to measure cardiac index instead. Now, when we look at cardiac output, we look at the components of cardiac output, and we look at stroke volume, and we know stroke volume in itself has some components that we need to take a look at. And so we're on page 1116, and it talks about preload. And you're looking at my picture, and you're like, why balloons? Why does she have balloons for preload? And when I think of preload, I think of stretch. So I think a lot of times of a balloon before we have actually inflated it, and then we fill it full of air and we stretch it. And so when you guys are looking at preload, if you think of one word, I want you to think of stretch. You're looking at the stretch or the actual muscle fiber tension that is placed at the end of diastole in the ventricle. And yes, it is affiliated with venous return. And so it needs to be just right. We need to just have a certain amount of venous return to the ventricles where it stretches that cardiac muscle, and then that cardiac muscle is able to snap back effectively. And so that's how we need to look at preload. When we look at afterload, if I think of one word that I could relate to afterload, I'm going to think of the word resistance. And so you see the next picture is of a hose. And so the hose ties us into afterload. And I'm thinking of resistance, and I'm thinking of the force in which the ventricles must overcome in order to open up those valves and actually eject its blood volume out into either the pulmonary or the systemic circulation. And so the more resistance, the more difficult it is for those ventricles to actually eject its blood volume. And so this is a great picture of a hose because it's kinked. And so for instance, guys, when you're thinking about systemic circulation and you're thinking of someone who has clamped down vessels because of hypertension or coronary artery disease, then you are realizing that they're going to have difficulty with an increase in afterload, and it's going to make the ventricles work harder than they need to. And then the last thing that we need to talk about is contractility, the last component of stroke volume, and that's just the heart's ability to effectively contract. And everything needs to be lined up just right. Later in the PowerPoint, there is a video that I've embedded, and it does show you that if we overfill, for instance, the ventricles with too much venous return, and we have a high preload, that it actually will separate or pull apart the swivels, and so then the heart muscle is not as effective in contracting. And if we do this repeatedly, it has a long-lasting effect. And then when we talk about the heart rate, you guys understand that the heart rate is actually controlled by the sympathetic nervous system. And not only does the sympathetic nervous system control the heart rate, but it also controls many other factors. Okay, just a few of the diagnostics. First, let's talk about the lipid panel. The lipid panel, you guys understand, is like fatty substances. Looking at your cholesterol, your triglycerides, your HDL, your LDL. This is a serum blood test. It is fasting, and it's going to tell us your risk of cardiovascular disease. You know, are you going to develop coronary artery disease, peripheral arterial disease, and a lot of times based upon these results, someone might be placed on a statin, which we'll talk a little bit about later. Cardiac markers. Cardiac markers. An individual comes into the ER, they're complaining of chest pain, which is angina, and then we're going to do cardiac markers. Another serum test that picks up when an enzyme is released from damaged cardiac muscle. The most popular one is the troponin. There's a few different troponins. I believe, for instance, Baycare does the troponin I, and so we do that upon admission, and then typically get 2 more sets about 8 hours apart, looking for the possible onset and peak and duration of these cardiac markers, signifying if someone actually has myocardial muscle damage. A 12-lead EKG. Again, someone comes into the ER, they're complaining of chest pain. We're doing these 2 together, guys. So upon admission, you're getting cardiac markers, you're getting your 12-lead EKG, and you're going to have a couple of more approximately 8 hours apart. And we're looking at the 12-lead EKG, which has multiple views. You guys will learn more about this in adult health too. But what we know is that there is a point on an EKG tracing that's called the isoelectric line, when all activity should be absent. And what you can tell here on this particular series is that we have what we call ST elevation. So you guys understand this is the P wave, this is the QRS, and this is the T wave. And at this point, the T wave should not be elevated. And so we're going to look at this not from the standpoint of a vertical or a horizontal axis, but a vertical axis, and we can count these boxes, and each little box is worth a millimeter. And we can see that the ST segment is elevated. It did not return to the isoelectric line, and therefore this is considered ST elevation and significant of possible myocardial muscle damage. Most of you guys know about echoes. You know that an echo is a really great test. A lot of times when we think someone has heart failure, cardiomyopathy, we're going to look at an echo. They have valve disease, for instance. A regular echo, non-invasive. But if we feel like we need a better view, we need to actually get closer to, we can do a transesophageal echo, that's the TEE, but that is invasive, guys. So this individual now has become NPO, they're going to get an IV, and they're often numbed up and sedated, very similar to the upper endoscopy that we've talked about. The probe then is able to get closer to the heart, get to the posterior surface of the heart, and can be a little bit more useful. So that's a transesophageal echo. A stress test, there are multiple types of stress test. A stress test typically is we put you on a treadmill or a bike, we hook you to a blood pressure monitor, we hook you to an EKG, and we watch. What are we watching? We're watching for and looking for ST segment elevation that is brought on by exercise. A BNP, you guys understand a BNP is a hormone that's released from an overstretched ventricle. And again, a lot of times we monitor BNPs for people who experience heart failure. They come in, they're having an exacerbation of their heart failure, then we look at their BNP. It should be less than 100. So when it's elevated, we look at it, we're like, okay, they need a tune-up. We give them more Lasix, for instance, maybe mess with their medications, put them on a positive inotropic drug, and then retest and see if we have been successful and brought their their BNP down. And last but not least, we're going to talk about a cardiac cath, the left-sided cardiac cath. Okay, so we've talked a little bit about this during the semester, where we've talked about an angiogram and angiography, where we actually we access an artery, and then we pass a catheter through it, and we shoot dye in. We want to look at arteries. Okay, a left-sided heart cath is no different, guys. So we want to access the artery. Typically, it's either the femoral or radial, and we can take dye, shoot it through the catheter that's been placed, and then we can take a look and see, okay, are there any blockages for the coronary arteries? And this helps us to determine if there needs to be intervention as far as opening up these potentially blocked coronary arteries. So pre-procedure, you guys understand what needs to go on. We need to be concerned about the dye, any medications that need to be stopped, and make sure the kidney function's good. Post-procedure, they come back, they've had some sedation, let's make sure they're stable. But also you have a site. Let's make sure that the site is not bleeding, there's no hematoma, and that there's good circulation to the actual extremity. The good news about this particular slide is many of these things you guys understand. And so we don't even really have to talk about. You know that when we're looking at non-modifiable versus modifiable risk factors for perfusion, the non-modifiables would be, your gender, would be your age, would be your race, would be your genetics. But there are many, many modifiable risk factors for perfusion issues. So for instance, if someone does have elevated serum lipids, or we call it hyperlipidemia, then that is the individual that we need to focus on decreasing the amount of fat in their diet and making sure that they understand the difference between good fat versus bad fat. Hypertension. When you guys learn about hypertension and adult health too, you're going to understand that consistent high pressure on the arteries is a bad thing. That what it does is it roughs up the intimal or the most innermost layer of the artery that is supposed to be smooth, but it roughs it up, and it can lead to the aggregation of platelets, and if someone has hyperlipidemia, lipids, and set that individual up for coronary artery disease, possible a cerebral vascular accident, possibly peripheral arterial disease, possible kidney disease. And so if someone does have a history or does have hypertension, we need it to be well controlled. You guys understand tobacco use is what we go after first. When someone has a history of tobacco use, we know that it's a carcinogenic, but we also know that it is a vasoconstrictor, and therefore we want people to really try to quit smoking. Physical inactivity and obesity really go together. We need people to become physically active. We need them to try to exercise 5 days a week, at least to walk and do some strength training, and that if they are obese, to work on reducing their weight 1 to 2 pounds per week until they have a normal BMI or a BMI that's less than 25. If they have diabetes, we've talked about diabetes, you guys understand diabetes. It is one of the main reasons people, for instance, have renal failure, one of the main reasons that people have coronary artery disease, and so we need to focus on controlling the hemoglobin A1C. We talked about metabolic syndrome. You guys understand that this is multiple signs and symptoms, and that when people, for instance, have this combination of symptoms, it leads to an increased risk of diabetes, and that leads to an increased risk of coronary artery disease and renal failure. We understand that consistent high stress is not good for us. We know a little stress is good, but that if we consistently have a high stressful situations, it's not good. And that chronic stress can have consequences. And we know that it can lead to diseases, for instance. And one of those is heart disease. And so we need to learn how to actually handle our stress so it does not turn into or enable a disease process that we have going on. And then last but not least, the homeocysteine levels. This is something that's a little bit newer, but we realize that we have elevated homeocysteine levels, that this can lead to inflammation and actually lead to potential coronary artery disease. So I sat down and just typed up all the different potential exemplars for perfusion. And so what you guys can look at and realize is that many of these diseases, CAD is coronary artery disease, PAD is peripheral arterial disease, CVA is cerebral vascular accident, HF heart failure, dysrhythmias, hypertension, DVT, deep vein thrombosis, PE pulmonary embolism, shock, cardiomyopathy and congenital heart disease all have the potential to alter perfusion. And so if you come across these particular exemplars, then you realize that you can go back to the principle of perfusion and apply what we are learning. Okay, so the first exemplar that we're going to briefly introduce is the exemplar of hypertension. And you guys understand hypertension is just the elevation of your blood pressure, and typically this goes along with it being high on two separate occasions. So what you will find in your book is that there is what we consider normal blood pressure, less than 120 over less than 80. This has really recently become very tight. It is now considered an elevated blood pressure, or what we might classify as pre-hypertension, for 120 to 129, and still a diastolic of less than 80. We get into stage 1 is 130 to 139 or 80 to 89, and stage 2 is 140 or higher with your diastolic 90 or higher. And then in your book it continues to outline what would be considered a hypertensive crisis. The main thing is that the categories of the blood pressure levels in the last few years has tightened, and many individuals do not realize that they are suffering from prehypertension and that it should be addressed. We often call hypertension the silent killer because a lot of people just incidentally find out that they have hypertension. They pop into Walmart or CVS, take their blood pressure, and realize that their numbers are higher than they used to be. And so a lot of times people do not actually have physical signs and symptoms of hypertension. When they do, a lot of times it is a headache when they first rise in the morning, or fatigue, a reduced activity tolerance, dizziness, maybe some shortness of breath, chest pain, or palpitations. One of the issues with hypertension is that they don't understand what's going on inside of them. But someone who has hypertension, we've already talked about, it is a leading cause of coronary artery disease, renal failure, left ventricular hypertrophy, a leading cause of heart failure, people having stroke, retinal damage, which is damage to their eyes. And so we really need to explain to individuals, while hypertension doesn't necessarily make you feel bad, this is what's going on inside your body, and this is what's happening to your arteries. This is why we need to decrease your blood pressure to decrease the potential target organ damage. So when we're looking at the treatment of hypertension, we focus on those lifestyle issues that are modifiable. So this is someone we're like, okay, one, the particular type of diet that is utilized for hypertension is called the DASH diet, and that stands for the Dietary Approach to Stop Hypertension, and it is essentially just a heart-healthy diet, but it does focus on decreasing sodium. We'll also ask this individual to quit smoking. We'll ask them to become active, and we will ask them to reduce their weight if they are overweight. And then you guys can review the posted medication PowerPoint and realize that you know many of these drugs. You know the diuretics. The diuretics help by decreasing preload. They help decrease the stroke volume and therefore decrease the blood pressure. A lot of times they're on beta blockers. Beta blockers end in LOL, and you guys understand the ACEs, and that's the prils. And so you guys can review those particular medicines and realize that we often start someone on single therapy, give them a chance to hopefully introduce some lifestyle modifications, and then if necessary, put them on additional drugs as needed. Okay, next guys, we're just going to briefly get into coronary artery disease, and you'll find that this can be a few different things, but mainly what we're looking at here is that an artery that has become diseased, whether there's a narrowing because there's atherosclerosis, or possibly the patient experienced a embolus, but anyway, something has interrupted the blood flow through that artery. First, just want to point out that you want to be aware of certain populations that can actually have coronary artery disease and be asymptomatic, and that's the diabetic population, women, and the elderly. Next, atherosclerosis. This happens over time. It's progressive. You have a buildup of plaque, and what happens as this plaque builds up, it invades the different layers of the artery, and therefore it impedes the blood flow through the artery. Next, we have angina. You guys know angina as chest pain. And what happens with angina is that you have a narrowing in one of the coronary arteries, and you do something that causes an issue between supply and demand. You, for instance, let's say, go out for a jog, and it is hot, you're not used to jogging, and then you have your first episode of chest pain because you have a narrowed coronary artery that you don't know about, and your heart cannot supply enough oxygenated blood to that particular part of the heart to meet the needs, and you develop chest pain. You stop, you rest, the blood flow is reestablished, and then what will happen is the chest pain will subside. When we look at angina, you look at stable, means it's predictable. That's probably the best word, predictable. When you look at Prince Metal, what we're looking at is chest pain that's not typical. It is associated with coronary artery spasms, and then unstable, best word is unpredictable. It happens sometimes even at rest, meaning that sometimes even at rest you have chest pain. Next, we take it a step farther than angina, and we have someone who has actual myocardial ischemia. So something's happened, whether it be a coronary artery spasm, maybe the patient's severely anemic, low blood pressure, maybe they have an occlusion in one of their coronary arteries, a clot has happened, and we switch from aerobic to anaerobic metabolism. And what happens here is then that lack of oxygenated blood just irritates the nerve endings in the cardiac tissue, and you have the buildup of lactic acid. The lactic acid actually irritates the nerve endings, producing the chest pain. So, but hopefully what can happen at this point is we can again realize that we have a unequal balance between supply and demand, and we can fix it, equal it back out, reestablish the blood flow, and we can get through an episode of myocardial ischemia without actually having cardiac muscle damage. Next, a myocardial infarction, whether it be an embolus versus a thrombus, but this is ongoing unresolved myocardial ischemia that occurs, and we're not able to reestablish the blood flow, and now we actually have dead myocardial tissue. The problem with an MI is that often within the first few hours these individuals die. There is up to 40% that die prior to even getting to the hospital to get help, and the issue here are dysrhythmias, the lethal dysrhythmias that you guys are going to learn about in adult health too. When someone presents with chest pain, we certainly want to go through the whole scenario of the PQRST for the chest pain. But one thing that we want to know is, have you had this type of pain before? And if not, then we need to be concerned. So, established pain, PQRST. A lot of times people will tell you it's searing pain, crushing pain. I feel like there's an elephant sitting on my chest. It goes into my, left arm, up my left side of my jaw and my neck, between my shoulder blades. Can be a tightness or a fullness, and it's pain that is lasting for more than a few minutes, but when it does go away, often it comes back and it's more intense. And so just establish what their pain pattern is, establish when the pain started, establish if this is like pain that they've had before. I just wanted to show you what happens when someone develops atherosclerosis. This is what's going on. you have a plaque buildup. These plaque buildups often form a fibrous cap. And so as you can see here, I don't know, maybe 40% of the blood flow is getting through. And so if you're at rest, you're probably going to be okay. But if you do something that challenges your cardiac muscle, then you can understand with this particular buildup that you could develop angina. And then if something happens, let's say you guys decide to be crazy, move up north, go out and shovel some snow, that plaque cap ruptures, leaks out into your coronary artery. Now we have what we call a thrombosis formed. And you can see now, this is 100% occluded. This person's going to have a significant episode of myocardial ischemia. And if we do not do something to reestablish the blood flow, this is the person that's going to actually end up having an MI. So in general, when we look at someone who's having an episode of angina, we look at them kind of like a puzzle and realize that there is an imbalance between the supply and the demand, and that we need to look at them and say, okay, how can we actually reestablish this? How can we increase the supply of oxygenated blood to your cardiac muscle or decrease the demand? And so we just want to reestablish that. A lot of times when people have episodes of chest pain, we have an acronym that we go by, and it's called MONA. It stands for morphine, oxygen, nitrates, and aspirin, not necessarily in this order, but it kind of gives us a general idea of how we're going to greet chest pain patients. And so a lot of times when EMS arrives, what we'll do is go ahead and place them on some oxygen therapy, whether it be by a nasal cannula, a mask. It just really depends on what their oxygen saturation is. And again, you can see that we're just trying to increase the supply of oxygenated blood being delivered. We, a lot of times, will go ahead and give them typically a baby aspirin and have them chew it. We're looking at this for its antiplatelet effects. And then nitrates, okay, nitroglycerin. So nitroglycerin, typically we're going to give a patient, we're going to either use the spray or a sublingual. The sublingual goes underneath the tongue. We can give them 3 doses. They're 5 minutes apart. When we're doing the nitrates, we're always checking to make sure that the blood supply or the blood pressure is adequate in order to give the nitrates. We are actually checking the pain level. Are they still having pain? And what you guys will learn in adult health too is, for instance, that we need to identify if the patient's on any kind of erectile dysfunction drugs, such as Viagra, in the last 24 hours. And also you'll understand that if we're suspicious that possibly they're having a right ventricular infarct, we would be cautious in delivering nitrates. So that's a start with the nitrates. We can always follow up with nitroglycerin in a patch form. We can also follow up with nitroglycerin in an IV infusion form. And if the nitrates aren't cutting it, then we can go to morphine. We can give morphine, typically give a pretty good dose up front, maybe 4 to 8 milligrams, again, as long as the blood pressure can support it. And then give them smaller increments and just trying to decrease their amount of chest pain that they're having. When they get to, hopefully, a certified chest pain center, they're going to figure out quickly, is this someone who is actually having an episode of angina versus an episode of actual ST segment elevation, or actually having a STEMI or an MI, as we would call it. And as we said earlier, this is someone who's coming in. We're going to do just a wide variety of labs, but to include those cardiac enzymes, I only talked about one of them. That was the troponin. But there's other cardiac enzymes that they will look at. And obviously they're going to look at that 12-lead EKG. And we need to understand, is this someone who's having an acute coronary syndrome? And so we're just trying to verify, is this an episode of angina versus acute coronary syndrome? And if it is someone who's actually having an MI, then what can we do to reestablish the blood flow to that particular part of the cardiac muscle? So a couple of different options would be, if these individuals are candidates, is what we call fibrinolytic therapy. Maybe you guys have heard this called clot busters before. And so with the clot busters, this is a particular type of medicine. Probably the most popular is TPA. And TPA, what it does is it actually dissolves clots. And so there's an extensive checklist that will be implemented to make sure that this patient is a candidate for fibrinolytic therapy. And if they are, it is administered intravenously, and it will break up that clot and hopefully reestablish blood flow to the cardiac tissue. And maybe we can get to them in time, and there'll actually be no cardiac muscle damage. But you have to realize with fibrinolytic therapy, it's not just going to break up a clot that's in the coronary artery, it's going to break up any clot that you have in your body. Maybe you're not a candidate for fibrinolytic therapy, then it's possible that you're a candidate to go down to the cath lab, do a left-sided heart cath, take a look, find the occlusion, and hopefully intervene in the cath lab. And so again, this is something that you guys will get into extensively when you enter into adult health too. I know many of you guys have been fortunate enough to actually go to the cath lab this semester. And last but not least, just a brief overview of heart failure. Good news here is the majority of you guys have taken care of a heart failure patient in the hospital, and you realize that it's pretty popular, and the leading causes would be hypertension and coronary artery disease. And so when we're looking at heart failure, it's just the heart's, kind of worn out. It has lost its ability to meet the needs of the body. It can no longer pump enough oxygenated blood out into the systems to meet the needs of the tissues and the organs. And so we're just going to briefly look at left versus right-sided and a few of the treatments. Okay, heart failure, left-sided versus right-sided. First of all, we don't typically see a lot of, hey, I'm left-sided, that's right-sided. We usually see a mixture of both. Remember, left-sided heart failure can become right-sided heart failure, and so that's why we see a lot of both types of left and right-sided signs and symptoms. You'll notice in the PowerPoint that the heart failure up here is an actual hyperlink, and so if you watch that short little video, very basic, but gives you an understanding of what's going on. We do see left-sided because we see a lot of people who have hypertension and coronary heart disease. And as I said, left can lead to right. So what's going on is that if you just think about the left ventricle and you think about the fact that the job of the left ventricle is to empty that load, and it has to overcome the resistance of the systemic circulation. And let's say that, hey, you have some crazy hypertension or coronary artery disease, and it cannot empty its load. Then what's going to happen? It's going to back up, right? So it's going to back up. It backs up into the pulmonary. Okay, it backs up into the pulmonary system, and you get pulmonary congestion with that particular type of decreased cardiac output. So that person is I'm short of breath, and they complain of it. They have a cough. A lot of times it is actually rather moist. They have orthopnea, just meaning, they tell you, hey, I sleep at home at night on 3 or 4 pillows, or I sleep in the recliner. They have crackles. They can't get up and move about the room very well. They can be dizzy, have wheezing, develop a gallop. And again, left can become right. Okay? True right-sided heart failure is unusual, but you do see it with people who have, for instance, cystic fibrosis, COPD. Maybe for some reason somebody has pulmonary hypertension. And so then you're on the right side and the right ventricle, and it's difficult to eject its blood volume into the pulmonary system. And so then your backup, though, then becomes more of venous congestion. And so you have engorged organs, they're congested. You can have an enlarged spleen, for instance. This is someone who becomes squishy. They develop a lot of tissue edema. A lot of times they develop edema, what we call anasarca, where it's just the entire body. A lot of times because of just the generalized edema and organ congestion, they're nauseated, they have a lack of appetite, and they have what we call JVD, and I'm pretty sure you guys have heard or actually know what JVD is. And so that's right-sided. But like I said, guys, we usually see a pretty good mixture. If you wanted to, you can take a look at page 1233 in your text, and it kind of goes over all the various signs and symptoms an individual might display when they have heart failure. So we've really not talked about these terms before, but no time like the present to learn them, right? And so anyway, you might hear, for instance, that a drug is a chronotropic drug. So the word chronotropic, when you're looking at it, just means that it is actually affects the heart rate. And so a negative chronotropic drug, for instance, would decrease it. Positive would increase it. A lot of times you guys will hear that a drug is an inotropic or an inotrope. And so just realize that an inotropic drug has to deal with the fact of it's changing the strength of heart contractions. And so if it's a negative inotropic drug, then it is decreasing the strength of contractions. And if it is a positive inotropic, it is increasing the strength of the heart muscle contractions. And this is important because when we're looking at the effects of certain drugs for heart failure, a lot of times we will say that it's a negative inotropic drug, so you have to be cautious, or it's a positive inotropic drug and it would improve contractility. So the good news is the majority of these drugs you guys have seen. I know that you've seen the diuretics, you're very familiar with beta blockers, you're very familiar with ACE inhibitors, and so what you're going to realize is it comes down to this. When you're in adult health too, you're going to realize that when you look at an ACE inhibitor, it's just not utilized for hypertension, but that it has many uses. And when you look at diuretics, it's not just used, again, for someone who possibly has hypertension, but it's also used for someone who has fluid overload in general, maybe has heart failure. And so you're ahead of the game here, guys. And so if you wanted to, on page 1237, it goes through the various meds that are used for heart failure, but honestly, a majority of them you know. Probably the one that you're most unfamiliar with is what we call digoxin. Digoxin is what we call a cardiac glycoside, and it is a positive inotrope, meaning that it just improves or strengthens cardiac contractility. And because of that, if it improves or strengthens cardiac contractility, it'll increase your stroke volume and your cardiac output in general. But it also has an effect, and you guys are going to find this out next year, that many of these drugs also have an effect on the heart rate. And digoxin is no different. And so we have to not just monitor the blood pressure, but monitor the heart rate. The other thing that we want to be cautious about is someone who is on DIG with a diuretic that is potassium wasting, because we know that digoxin is sensitive to a patient who is hypokalemic. It actually intensifies the effects of the DIG. And so if you have someone on DIG and a potassium wasting diuretic, just make sure they do not become hypokalemic or have a low potassium, because then they could actually appear DIG toxic. Even though their DIG level might be normal, they would appear DIG toxic until we actually corrected their low potassium. And so overall, guys, you know most of these drugs. What you're just going to realize is that you're going to learn more about the drugs and realize that they're used for many different issues for the concept of perfusion. So listen, I hope this is helpful to help you guys prepare for HESI.